Welcome to Season 4, Episode 3 of the 6 Lessons Podcast. We're so glad that you joined us. We've had over 10,000 views of this podcast. We're excited to spread the word of new treatments, new techniques that it can allow long-lasting restorations without destructive preparations for fillings, crowns, root canals, and obviously extractions and implant. But each of you in this episode will learn the history of what has been tried to help teeth that have cracks in them. And of course, if a tooth has a crack and it's into the root and the PDL is hurting, even if the pulp has been taken out, it hurts. And so the first pain that comes from a crack is from the pulp. The second source of pain is from the PDL. And so cracks can kill pulps, but still cause pain. And that PDL, sensing the pain, will not make the patient comfortable. And so quite often those cracks into the roots have been the catastrophic failures where teeth are extracted. But when I went to dental school in the middle 70s, 75 to 78, we did understand that there was a symptom of repeated pain on biting that could be diagnosed. Then there was a treatment that was taught since the middle 60s for 10 years, first recommended by Cameron out of the University of Southern California for what he titled cracked tooth syndrome. Now, cracked tooth syndrome in the 60s was before the book that was actually published on it in 1982, and that was by Martin Brandstrom, and we've referred to Martin Brandstrom diagnosing pain and the source of pain in a vital tooth being the movement of the pulpal fluid. But the source of pain after the pulp has been taken out, that was pioneered by this team from the University of Southern California, Cameron. And so when I was in dental school, I was taught the pathology and taught the diagnosis of cracked tooth syndrome, repetitive pain on biting. We had an instrument called a tooth sleuth that could reproduce when you bit on it. It wasn't an expensive plastic instrument, kind of like the end of a toothbrush handle. And you could find out, and every time they bit down, yeah, it hurts. Yeah, it hurts. Well, you've got cracked tooth syndrome. So the diagnosis was cracked tooth syndrome, but the treatment that Cameron had been using at University of Southern California, which had some success, was full coverage. And his theory was a mechanical holding together of two pieces that are moving. Again, he was not sophisticated in the hydrodynamic theories of pain that were published by Brandstrom 15 years later. But the idea is that everybody knew that if you have a tooth you can't bite on, that's a problem. The dentist, what's the solution? When it hurts, well, to take the pulp out, that was something that happened quite often. But if you take the pulp out of a tooth that has a crack in it, and you do any kind of restoration, you still have the potential to have that crack continue to propagate. And of course, that piece of science comes from engineers. It didn't come from dentists. And I've never found a dentist that's really talks in those terms that the engineers have been using for, again, 100 years. Crack initiation, crack propagation, catastrophic failures. These have happened on bridges, have happened in ships, have happened in airplanes. These kind of engineering ideas of crack initiation, crack propagation, and the stresses that it takes for that to happen, this is something that was not in any dental school. If there's any dental school right now that's teaching in those terms, I'm not aware of it. But crack treatment with the cracked tooth syndrome has only had mixed results. How do I know? Well, I've talked to thousands of dentists over the last 22 years, and I've trained hundreds, maybe 1,000 dentists in the specific technique that I developed to treat cracked tooth syndrome in the year 2000. And so in the year 2000, I started to talk to engineers. I knew two that were friends. One lives in my neighborhood named Dennis Grohl, and then another engineer that actually worked at Ultradent, which is obviously a dental company, but his expertise at Ultradent was not on cracks, but I was using Ultradent's library, and so his name was Robert. And I said, Robert, what did you learn in engineering school about cracks? And he talked about crack initiation, stresses and strains, a stress-strains curve that's related to Young's modulus or modulus of elasticity. I mean, this is a foreign language. This is something that most people every day don't learn about. But the idea is when I started talking to engineers and they had the same language, and they referred me to some books and some literature. And I'm going to bring out a book right now. Just happen to have one on my shelf. I hope it's still there. So here is the book that we're going to recommend. The New Science of Strong Materials. The subtitle is Why You Don't Fall Through the Floor. That's a joke. It's not a joke if your floor is solid and you're not falling through a floor. But there are ways to create situations where you would fall through a floor. And we won't get into the history of that, but Gordon is the engineer that actually first integrated some dental ideas into his book. And it had to do with cracks and those cracks that were in dentin. This illustration, for example, shows that a crack, this is all cracks of all materials, all strong materials. Once they start separating, there's always a point of energy concentration at the tip of a crack. So, what do engineers do if they have that situation in $1 billion airplane? They actually blunt that crack. They go to the bottom at the tip, they have a round burr, and they make it round instead of pointed. What does that do? It means that if you have a round area and you have stresses that are coming into this hard material, if you have a crack, the hard material starts to concentrate stresses right here, and it's enough to break the molecules. But if you have a rounded surface free of cracks, then the stresses that are coming into the material are distributed through the whole round surface, and that distribution means that there's no new crack formations. And so I hope that each of you are inspired to become at least conversant with the engineering terminology. And how many books do you have to read? I've read dozens of books, but basically I needed a mentor. I needed a mentor who actually could help me understand the illustrations, the pictures. The mathematics was usually not something I was, because I grew up in a house of mathematicians, I knew that mathematics can get really beyond what I need practically. But the idea is that once I understood that the traditional idea of mechanically holding a crack together didn't work, that was what led me to talk to engineers, say, what does work? What do you do on $1 billion airplane? Could I apply that to what I do on a tooth that I'm going to fix for $1,000? And they said, oh, absolutely. Of course, the engineers don't know anything about biology. They don't know anything about connective tissue or bacteria. They really don't know anything about the hydration of the body. But the idea is that water is something that is essential to life. And the life of a tooth can't happen without hydration. In dentin, we have 20% of the dentin is water. Pulpal fluid is mostly water. That gives a toughness and a flexibility to dentin, but it also means that repairing the dissection is going to be a little tricky because you're using materials that are hydrophobic. Epoxy is hydrophobic. All of our bonding systems come from the initial invention of polymerizable epoxy resins that came by Castan in the 1930s. This overcoming of the difficulties of bonding, that's our expertise, but the idea of crack dissection, that's the foundation. And there has been many studies that have tried to do what Cameron and the traditional crack tooth syndrome treatment did, and they had maybe 60% success. Quite often, 50% success at 5 years. One important book was published in 2016 by Bodekari, and he had a whole chapter on cracks. He photographed them, very nicely. And then he was honest enough to say the adhesive techniques that we've been using, immediate dentin sealing, resin coating, composite in the box area, restoration, and deep margin elevation, he had 80% of what he needed to have complete success. But he was honest enough to say these cracks, they didn't respond the way we would like to the idea of adhesive dentistry holding these together. Mechanically, it didn't work. The adhesive restorations, that didn't work. And Botachiari documented that, showed that. Many studies from Europe showed the same thing. There was only one study that really shined a little bit of light on the potential of a new technique. Now, when I developed my technique independently, I didn't know anything about the endodontists that were using crack dissection. That was published in an Australian Journal of Dentistry in 2009. But Abbott and Lowe, in their practice in Perth, Australia, which is way out west, it's not very many people know about Western Australia, but the guy out west, they got the right answer. They had teeth referred to them by dentists saying they can't bite on this tooth. We're going to do a root canal. We want you to do the root canal. But Abbott and Lowe knew enough about pulps. They have more training in pulp biology, and they felt like the pulpitis was a reversible pulpitis, not an irreversible pulpitis. And of course, that diagnosis has to change based on what you believe, and you have used the pulp in a healing mode. And my basic diagnosis now of irreversible pulpitis is that I never make that diagnosis. If the pulp's dead, you won't have a pulpitis. You could have pain on biting, but that's not a pulpitis. Pain on biting in a dead pulp does come from the PDL. Anyway, so these evolving concepts that get mixed up in general dentists' eyes and minds and in endodontists, endodontists that is just, knows they get paid whenever they take a pulp out, they just take the pulps out. But the downside of taking a pulp out is the loss of that 20% hydration in the crown and in the root. And that means that you have 3 times less toughness and 3 times more brittleness. Those are engineering terms, again, that need to be understood. You can look those up, and any dictionary should give you that difference. But if you have a tough material, it'll have some give. You have some shock absorption. If it's a brittle material, at a certain point, you have a fracture. And that has to do, again, with this other concept, modulus elasticity, or Young's modulus. But the old technique of putting a crown on, maybe a coin toss of success. Then the next situation of adhesive, again, a coin toss of success. Why were these sometimes successful? It's because the crack can go in 3 different ways. It can go sideways, it can go in a oblique manner, or it can go vertical. Every crack that goes vertical always gets to the pulp. That's going to be pain. Every crack that goes sideways doesn't get to the PDL, and every crack that goes obliquely can get to the PDL, but also has the risk of going through the pulp horn. And so the diagnosis between a vertical, an oblique, and a horizontal crack, unless you understand that, it's based on anatomy, and it's based on understanding the origin of pain. Is it hydrodynamic source of pain? Or is it the nerves that are in the PDL, the connective tissue around the root, that are causing the pain? So you need to be very clear in those when you make your diagnosis. Davey has an excellent lecture, I believe. We occasionally make that available as a webinar. But that signature lecture that Davey gives is a 2-hour lecture. He's given it in many forums around the world, and it's been borrowed by Semabelli and presented in Japan. If you understand that this dissection of cracks and restoration using adhesive principles we've developed has been 100% successful. In other words, we get doctors every day that post on our WhatsApp group, patient came in, they had crack tooth syndrome, we restored it, but with dissection and C-factor control using small increments and rib-on and time to decouple the developing hybrid layers. All of these ideas that we've used for over 25 years now, quarter of a century, it solves the problem that is the 3rd leading cause of tooth loss. I mean, why wouldn't every dentist in the world be interested in learning the way to prevent the 3rd leading cause of tooth loss? You have to ask every dentist. That's not easy to do. But you are interested, and you have the opportunity to learn more. And in our next lecture, we'll talk even more about how to prevent tooth loss from cracks using the best system that's ever been developed. Till next time, get bonded, stay bonded.